Hi, welcome to ICS 2020 Online. I'm Howard Goldman from Cleveland, Ohio, and I'm actually one of the scientific co-chairs of the meeting, and we're glad to have you here. This session is Spotlight on IUGA, Childbirth, Will My Pelvic Floor Ever Be the Same Again? And we are pleased to welcome all the delegates who are watching. As you watch, please use the comments functionality to say hello, ask questions, and participate in the debate. And you can still post questions even after we are done, and faculty will be able to respond a little later. So I'm happy to say that ICS and IUGA have a good relationship, and we always have someone from IUGA, usually the president, come and give us a guest lecture, and it works the other way as well. Someone from ICS attends IUGA and gives a guest lecture there as well. It's always nice to be in some exotic place instead of my living room in Cleveland, but it is what it is. So without further ado, I want to introduce Ranee Thakar, who is the president of IUGA and a urogynecologist at Croydon University Hospital in London. And as I said, she is the current president of IUGA. She's the lead for urogynecology at her hospital, at the Croydon University Hospital in London. She has experience across a wide range of subspecialties within obstetrics and gynecology, including psychosexual medicine, female genital mutilation, and the prevention and management of obstetric anal sphincter injuries. She's published a multitude of research papers, chapters, edited a bunch of textbooks, and she is currently leading a Royal College of OB/GYN national project, which is aimed at reducing the rate of obstetric anal sphincter injuries and has shown good results so far. I've also had a chance to know her in some of my work with IUGA. I've learned she's an excellent teacher, and from many of the people that I've spoken to who have worked with her as well, she's counted on as a mentor for many of the young urogynecologists around the world, and really someone who has impacted their specialty, our combined specialty in a very positive fashion. So without further ado, we'll go to Ranee Thakar for the IUGA lecture.
I'd like to thank the organizing committee of this meeting for this kind invitation. Pregnancy and childbirth can be an amazing experience. Unfortunately, some women develop long-standing pelvic floor dysfunction after childbirth, which can have a devastating effect on their quality of life. So what do you tell your patient who asks you, will my pelvic floor ever be the same again? To do full justice to this topic, I'm going to start off by discussing the pathophysiology, and then we'll look at how childbirth affects the pelvic floor and causes pelvic floor dysfunction. So we'll talk about urinary incontinence, anal incontinence, pelvic organ prolapse and sexual dysfunction, and finally look at some management strategies. So what makes human birth so difficult? Well, there are several characteristics that set our species apart from other mammals. We are the only living mammal that habitually walks on two legs. We need assistance for delivery. On the other hand, non-primate humans deliver in solitude. 3 stages in the delivery process in a monkey are depicted here. You will note that the neonate is facing in the same direction as the mother, and that the mother is able to reach out and guide the baby easily as it emerges from the birth canal. This is just not possible in the humans who deliver mostly in the occipito-anterior position. Usually the woman is lying flat on her back, and it is just not possible for her to aid her own delivery in this fashion. The other thing that makes childbirth difficult is the size of the human brain compared to the pelvis. So here you will see non-primate humans have a much bigger pelvis in comparison to the brain. However, in the humans, the anterior posterior diameter of the brain is bigger than the size of the pelvis. So in humans, the head has to twist and turn as it makes its way through the pelvis, followed by the shoulders, which again have to rotate. The effects on the pelvic floor or the levator muscle are best demonstrated by computerized models, and this is a computerized model developed in Professor Delancey's unit. The blue sphere is the fetal head, and you can see its relationship to the levator ani muscle in the early second stage and in the late second stage as it emerges out through the levator hiatus. A lot of work in this area has been done by Professor Dietz, and here you will see a levator detachment immediately after delivery, and here is a demonstration on transperineal ultrasound and on MRI, which is done 12 weeks after delivery of the same woman. And what we know now is that levator ani detachment or avulsion doubles the risk of significant anterior and middle compartment prolapse and is also associated with the increased risk of recurrence after pelvic organ prolapse surgery. The other thing that can occur is disruption of the fascia as the fetus comes out through the vagina, stretching the vagina and the tissues around it. Not only that, but the pudendal nerve, which traverses closely in relation to the levator ani muscle, is stretched along with the muscle, and here you will see in these computerized images the nerve and the levator ani muscle at the beginning of the second stage and at the end of the second stage. So childbirth can cause nerve damage known as pudendal neuropathy or direct mechanical trauma, wherein the muscle, fascia, and supporting ligaments can be damaged. And this can cause pelvic floor dysfunction in the form of urinary incontinence, anal incontinence, pelvic organ prolapse, and sexual dysfunction. So what about urinary incontinence? Well, this is best demonstrated in this French longitudinal study, which was based on a survey wherein they found that the prevalence of urinary incontinence was the same at 4 months and at 24 months, that is 20%. They found that urinary incontinence persisted in 50% of women who had urinary incontinence at 4 months, and these women were more likely to have pre-pregnancy urinary incontinence. There was a remission in 49%, and these women were likely to have had a cesarean section. New urinary incontinence developed in 12%, and these were women who had a new pregnancy after index delivery. Urinary incontinence had a higher prevalence in women who had a vaginal delivery compared to a cesarean section. And what was really interesting about this study is that they found that intercurrent obstetric events influence postpartum urinary incontinence. So they found that women who were pregnant at 24 months were likely to have more severe urinary incontinence. The same was seen in those who had a delivery between 4 months and 24 months, but those who had no obstetric event actually found an improvement in the severity of urinary incontinence. This finding further illustrates the favorable course of continence during the late postpartum period, except in cases of new obstetric event, and this suggests that the repair of obstetric injuries continues during this period unless blocked by a new obstetric event. However, when one is evaluating pelvic floor dysfunction after childbirth, one needs to take into consideration the length of time since the event, and therefore long-term data is important. Mode of delivery is also important. As can be seen here, the risk of urinary incontinence almost doubles after vaginal delivery, and this has been nicely demonstrated in these Scandinavian studies. More importantly, Gahagan found that there was no difference between emergency and elective C-section. Urinary incontinence was more severe after vaginal delivery, and when they quantified it, they found that 8 cesarean sections would be needed to prevent 1 case of urinary incontinence. So what about anal incontinence? Again, this very interesting prospective longitudinal study on primipara showed that 1 in 4 primipara experienced anal incontinence in late pregnancy. 1 year later, 1 in 5 suffered from anal incontinence. Sphincter injury predicted incontinence of stool and flatus, whereas greater age and operative delivery predicted urgency. This indicates that identification and adequate follow-up of pregnant women with anal incontinence may reduce anal incontinence after delivery. The authors utilized a unique opportunity of following up these women at 6 years and found an overall prevalence of 14%, which was pretty much similar to 1 year. But they also demonstrated that mode of delivery had an effect on anal incontinence with time. At 6 years postpartum, women with instrumental vaginal delivery with or without obstetric anal sphincter injury had a higher prevalence of anal incontinence compared to women with cesarean section or normal vaginal delivery. So what happens in the long term? Well, again, this is very nicely demonstrated in this large Swedish study wherein they looked at women who had had 1 single birth and evaluated them at 20 years. They found an overall fecal incontinence rate of 13.6%. Flatus incontinence was even higher. This is a more embarrassing symptom. This was 33.4%. They found a higher prevalence of anal incontinence after vaginal delivery compared to C-section. When they quantified this, they found that 26 cesarean sections would be needed to prevent 1 case of fecal incontinence, with no difference in emergency and elective C-section. So what about pelvic organ prolapse? Well, this is a study that we conducted in Croydon University Hospital where I work. We objectively and subjectively assessed women in the antenatal period at 14 weeks and then followed them up also at 1 year and 5 years. We found, compared to the second trimester after vaginal delivery, pelvic organ prolapse significantly worsened at all time points. As far as cesarean section was concerned, interestingly, there was a worsening at 14 weeks, but at 1 year and 5 years, there was no effect on the objective assessment that was on POPQ score. And this suggests that some kind of remodeling must take place. When we looked at symptoms using a validated questionnaire, we found no difference between vaginal delivery and cesarean delivery in vaginal prolapse scores, bother or quality of life when we compared it from 5 years to baseline that was in the second trimester. This suggests that the physical aspects of prolapse are not severe enough at about 5 years, but probably become worse with time, and then women become more symptomatic. And the effect of time is demonstrated in these important studies, which showed that the prevalence of symptomatic pelvic organ prolapse doubled after vaginal delivery compared to cesarean section 2 decades after 1 birth. Infant birth weight and current BMI were risk factors for symptomatic pelvic organ prolapse after vaginal delivery. When Gahagan's group quantified it, they found that 12 cesarean sections would be needed to be performed to avoid 1 case of symptomatic pelvic organ prolapse. More importantly, they found no difference between emergency and elective cesarean section. The effects of vaginal delivery after childbirth are complicated further by instrumental delivery. The mode of delivery and the risk of pelvic floor disorders is very nicely demonstrated in this study from the US. Women were recruited from a community hospital in this cohort study 5 to 10 years after their first delivery, and they were followed up annually for 9 years. Participants were categorized into the following mode of delivery: cesarean only, spontaneous vaginal delivery and no operative delivery, and operative vaginal delivery. A questionnaire was administered as well as POPQ. Scores were carried out using the POPQ quantification method. Compared with spontaneous vaginal delivery, cesarean was associated with a significantly lower hazard of stress urinary incontinence, overactive bladder, and pelvic organ prolapse, whereas operative vaginal delivery was associated with significantly higher hazard of anal incontinence and pelvic organ prolapse. In addition to this, they found a larger genital hiatus was associated with the increased risk of pelvic organ prolapse independent of mode of delivery. And as can be seen in the slide over here, they also found that in pelvic organ prolapse, the symptoms occurred later on in life compared to the other symptoms. Postpartum sexual dysfunction is slightly different from urinary and anal incontinence and prolapse, as demonstrated in this very nice longitudinal study of first-time mothers. In this study, they showed that a large number, almost 89% of women, reported sexual health problems in the first 3 months after delivery. This seemed to peak at 3 months and gradually got better at 12 months. What was really important to note in this study is that at 12 months, the prevalence of sexual dysfunction was almost similar to the pre-pregnancy levels. This slide also demonstrates that sexual dysfunction can be of various kinds, ranging from lack of interest, lack of lubrication, vaginal tightness, and so on. But lack of interest in sex seems to be the most common. Although most women in this study contacted primary care practitioners during the first 3 months postpartum, only 24% recalled being asked about sexual health issues by general practitioners. What was even more interesting is that women who had a cesarean delivery had equivalent or higher odds of persistent sexual health issues, but had lower odds of being asked directly about this, because based on the assumption that those who have a cesarean section do not actually have sexual problems. And then if you look further at whether women had 3 or more sexual health problems, you can see that a large number, almost half, have sexual problems 3 months postpartum. These persisted but got lesser at 6 months and reduced to 33% at 12 months. But as you can see in the slide over here, it was almost equivalent to pre-pregnancy level. And this highlights the importance of trying to find out whether a woman has sexual dysfunction when you're counseling or looking after women in the postpartum period. Whenever we counsel a woman or are looking after women who have sexual dysfunction, it's important to find out about the mode of delivery, whether they have obstetric anal sphincter injury, the type of tear they had, whether it was sutured, as we know that women who have sutured tear have a high incidence of dyspareunia, whether they have other issues such as fatigue, stress, musculoskeletal pelvic pain, previous dyspareunia and depression, which is highly important, and also if they are breastfeeding, as all of these are associated with sexual problems. So does a cesarean section prevent a woman from getting sexual dysfunction? The term breach trial provides a unique opportunity to evaluate the planned method of delivery. This was a randomized study of vaginal delivery versus cesarean section for term breaches, and they followed up women at 3 months and 2 years postpartum. They found no impact of planned method of delivery on resumption of sexual relations, pain, or satisfaction with sexual relationships. But what makes pelvic floor dysfunction after childbirth so complicated is the fact that there's a huge overlap between the symptoms. And as can be seen here, the prevalence of 20 years after one vaginal delivery or cesarean section is 46.5%, of which 32% had one symptom, but 15% had 2 or more symptoms. This is probably because obstetric trauma leading to pelvic floor disorders is multifactorial. In addition, the risk factors for urinary incontinence, fecal incontinence, and prolapse may vary, although there are some that are similar, for example, age and obesity. And this is important because while one cannot modify age, one can certainly reduce pelvic floor dysfunction by reducing weight, which seems to be the most common risk factor for pelvic floor dysfunction. The lifespan approach provides a conceptual framework for the interaction of causal factors for pelvic floor dysfunction over time. This is particularly true for understanding the role of childbirth and vaginal delivery in particular in the development of single or multiple coexisting pelvic floor dysfunctions. Phase 1 of the lifespan model includes predisposing factors such as genetic predisposition and race. Phase 2 of the model includes inciting factors such as obstetric events. Phase 3 includes intervening factors such as age and obesity. And as I have demonstrated to you earlier, both age and obesity are associated with prevalence of pelvic floor dysfunction. So what do you tell your patient who asks you whether her pelvic floor is ever going to be the same again after childbirth? Well, you've got to present a balanced view. While you tell her about the effects on the pelvic floor, you also have to tell her about the effects of a cesarean section. A direct comparison with cesarean section is difficult because there are no longitudinal studies looking at the effects of cesarean section. But we do know that a cesarean section is associated with immediate risk, delayed risk, and also risk to future pregnancy. And one also has to bear in mind that once a woman has cesarean section electively to protect her pelvic floor, she probably will end up having multiple cesarean sections if she has further pregnancies. The other thing to bear in mind that there are also effects such as placenta previa, placenta accreta, placental abruption, increased risk of miscarriages, ectopic pregnancy, and stillbirth, and even a higher risk of a hysterectomy, and this is something that is never told to patients who request elective C-sections. The other thing to bear in mind that elective C-section is not entirely protective, as we do know that nulliparous women have been shown to have urinary incontinence, anal incontinence, and also prolapse. And what is even more interesting is that there is a higher incidence of anal incontinence in nulliparous women compared to men. So to conclude, vaginal delivery is associated with a higher incidence of pelvic floor dysfunction. It's much higher with the instrumental delivery and lower with the cesarean section. But cesarean section is not entirely protective and is also associated with complications. We therefore need to focus on preventative measures, looking at modifiable risk factors, encourage pelvic floor muscle exercises in the antenatal period and the postnatal period, and focusing on weight reduction. And as clinicians, we need to work to make vaginal delivery safer. Thank you so much for your kind attention.
Thank you, Renee. So that was a very, very nice presentation and a lot of good information there. Wow, what timing. Hang on. Sorry, sometimes life intervenes and the phone rings and we don't get to. Let me ask you a question, then I'll mute myself.
Sure.
Question. Is it the fact that someone has an instrumented delivery or the fact that they needed an instrumented delivery that's the risk factor?
So from the data that we have, it's really difficult to decipher what actually it about the instrumental delivery that causes pelvic floor dysfunction. Is it what happened before, or was it this instrumental delivery? And it possibly is a combination of the two. But what we do know is that instrumental delivery does affect, as I've shown you, all aspects of pelvic floor dysfunction, all symptoms. But what obstetricians don't tend to take into consideration is that it's even worse for forceps compared to a ventouse delivery. We definitely know from all the work that Peter Dietz has done that it affects the levator ani muscle. The work that we have done, it affects the anal sphincter. And surely we should be looking at ways of preventing instrumental delivery if we can, and if we have to use an instrument, it should be a vacuum rather or ventouse compared to a forceps.
Okay. One of the questions here, I guess in my introduction, I talked about a project that you're working on to prevent injuries. Can you tell us more about that?
Yes, so it's a very interesting project. As I said earlier, that project is mainly focusing on obstetric anal sphincter injuries, and the aim is to reduce OAC. It's a quality improvement program which is done by the RCOG, that's the Royal College of Obstetricians and Gynecologists, and the Royal College of Midwives. It's something we started 5 years ago, and it was in response to the rising rates of anal sphincter injury in the UK. And the then president asked us to look at ways of trying to combat this. Now we realized that we couldn't actually do anything about this unless we worked with midwives, because most deliveries, normal vaginal deliveries, are carried out by midwives in the UK. So if you look at numbers, they are more likely to have anal sphincter injuries compared to only 20% of instrumental deliveries. So we developed a care bundle, and the care bundle consisted of providing information to mothers antenatally, because we know from experience that a lot of women in the antenatal period are not informed about pelvic floor injury at all. We included doing manual perineal support, and this was typically the type of support that is carried out in Norway. It actually originated in Finland, and doing an episiotomy correctly, that is at 60 degrees at crowning. And last but not least, we also included diagnosis, that is doing a per-rectal examination. And we introduced this care bundle in 16 units and have just last month published our results. We found a 20% reduction in OAC. And now we are doing a further upscaling project where we are trying to look at ways of intervention. So what are the best ways of introducing this in 30 different units?
Thank you. All right, here's a question that may put you a little on the spot, but we'll see. If you had a healthy friend of the family, 24 years old, pregnant for the first time, and she asked you, should I have a C-section or vaginal delivery? What would you tell her?
I would ask her what her, so it all depends on how we counsel her, whether she's your patient or your friend. I would want to know what she wants, A. So in the center of everything, all the advice I provide would be my patient or my friend, whoever it is. I would tell her what I know about pelvic floor injury after childbirth, be it C-section or vaginal delivery. But I would also tell her what can happen after cesarean section. I think one of the things that patients never told about is the complications that can occur with the C-section. At the end of the day, it is a laparotomy. And the other thing to bear in mind, once a cesarean section, always a cesarean section.
Okay. So I think we have come to the end of our time slot. So I wanted to, on behalf of the ICS, I wanted to thank you so much for joining us. And I just wanted to tell all of the participants to please, this is the end of today's live broadcast, but we have 3 more days. So we look forward to seeing you tomorrow. And of course, a lot of these will be available on demand. So everyone have a good day, morning, evening, wherever you are. And again, Ranee, thank you so much.
Thank you so much.